Friends, this is the OPU trolley. Here we have the test tube warmer in which we have the test tubes. This is the tubing which is attached, the suction tubing. This is the OPU needle which we will be using. Now for the cleaning of the patient, we do not use betadine. We use normal saline. So we've taken normal saline in the container and we've already clean breaked our patient. At the same time, this is the probe, the TDS probe. As you can see, this is the biopsy guide which we attach to it, and the needle would traverse through this for the procedure. So here we go. Here to the patient. Now this is a well stimulated ovary. We can see so many follicles. So we will take the OPU needle and insert it, and under ultrasound guidance we are going to puncture the ovary with this needle. You can see once we are going inside the follicle. As we go inside the follicle, we can see the follicle collapsing. हो जाएगा आ रहा है इसी की हवा मेरे मुंह पे पड़ रही है. Check the suction pressure. The suction pressure should be 100 to 120. As we take the follicular fluid in the test tubes, we directly pass it on to the IVF lab. As you can see that we pass on through the small window. Manoj ji pass on kariye. And now he is passing on the fluid through the window to the IVF lab. At the same time, the embryologist will look at the follicular fluid and tell us that we have obtained the oocyte or not. Now, since this is a case of OHSS, it is a hyperstimulated ovary, it's a PCO patient. Even though we began with an ultra-low dose of gonadotropin, we can see lots of follicles. So we have given her a decapeptyl trigger. As the needle punctures the follicle, we can see the collapse of the follicle. Check out the pressure. 120. पूछो किस साइड है हवा ऐसी है तो बंदी को तो सारी मेरे बंद है. Now this is a follicle on follicle. You can see first we are taking the outer follicle. Now it is fully collapsed, and now we shall be taking the inner follicle. Once the follicle collapses, it is always good to do a gentle curettage of the follicle for the complete evacuation. As we know that the oocyte is attached to the periphery of the follicle, it is always important to empty the follicular fluid completely to obtain the oocytes. Alright. So once we obtain the information that yes, we have obtained an oocyte, we know it is not an empty follicular syndrome and we are getting oocyte, our trigger has acted. We take all the follicles in the direction of the needle. It is important to keep the needle under vision at all times. आ रहा है ना? आ रहा है आ रहा है हाँ वो इसकी सिस्टम भी थी देखो ट्रिगर Usually, the anesthesia that we give to the patient is a short GA, but in such cases where we have OHS and we have multiple follicles, it is good to give the saddle block to the patient so that we get ample time for the pickup, as well as the patient does not move due to bucking the respiratory movements during the procedure. This we can see, this is a cyst formation. All these cysts have to be emptied. Sometimes, usually the follicular growth is not uniform and we can have few of the follicles very large, few a little smaller. So yes, we do have few of the follicles do convert to cystic formation. Nevertheless, we aspirate all. The smaller ones, the bigger ones. The smaller ones the aspiration of the smaller ones is as important as the bigger ones because they are responsible for production of large amounts of estrogen and henceforth the OHSS. Complete emptying of the follicle is very important. Always first withdraw the needle and then move the probe. Take the needle to the surface of the ovary when we move the probe. Never be deep inside the ovary while moving the probe, otherwise we are going to shear the entire ovary. Now the follicular output rate is expected to be 70%. When we give HCG trigger, the follicular output rate may be as high as 80 to 90%. With the decapeptide trigger only, it falls down to maybe about 60-70%. It is important to identify the outer border of the ovary so that we do not overshoot it. Gentle curettage of the follicle ensures that the oocyte definitely sticks on to our suction pressure. Now you can see even the smaller follicles are as important to aspirate to prevent the OHSS. Gentle movement of the probe while we are moving from one follicle to other enables us to focus on the ovum pickup and each and single follicle carefully. Now this is a lateral border of the ovary. We shall be picking up each follicle one by one. As you can see, as the suction pressure evacuates the follicle, it just simply closes in front of our eyes. Gently withdraw the needle before we focus again and aspirate the rest of the follicles. While we are aspirating, it is important to differentiate between the refills and the original follicles. Sometimes the refills will also give an appearance, but usually the appearance is quite hazy. Now this appears to be a refill. I am puncturing it. So the fluid that we would be getting would be more like a bloody rather than the clear follicular fluid. We have more to it. This is a cyst formation. We are aspirating the cyst also. Again, this is a lateral border of the ovary. For complete emptying, we sometimes have to go deep inside. Coming. As the follicular fluid keeps coming, the assistant keeps on saying coming, coming. Otherwise, it is very difficult to find out whether we are aspirating or it has stopped. So the uh, continuous information by the assistant in terms of coming, coming tells us that the follicular fluid is coming. It adds on to the reconfirmation. Otherwise, when we see on the fluid on the screen that our follicle is collapsing, we know that the fluid is coming. Done. Occasionally, it may be difficult to approach the ovary, and then we have to do the transvesical or even sometimes through the transcervical route. Looks sweet. नहीं आ रहा चलिए अब आया ओके नहीं बेटा यही है ये वाली तो यही है Now this is a refill. You can see how it fills up with the white. Blood is white, so it looks white in color. Blood आ रहा है So once we aspirate the refill, we get the blood instead of the follicular fluid. So this ovary looks almost complete. Yeah, we have one follicle in the edge. Yes, we shall be taking it. Yes. Yes. Even these smaller ones are important to prevent OHSS. In such cases, to prevent OHSS later on, we use multiple strategies. We use cabergoline, we use letrozole, we use antagonist. Monitoring and closely watching the patient is very, very important. Now, this cabergoline can be given right from the time of trigger. The moment we give trigger to the patient, we tell the patient to start taking cabergoline so that the OHS can be prevented. At the same time, somebody goes to take the semen sample. The semen sample needs to be processed before it can be used for the procedure. See, as we can see, this is a cryocan for freezing the embryos. Now, this is a co-diet for air filtration. Even though we have an AHU installed, there are all steel walls. We still have put this co-diet for air filtration. Now, this is a benchtop incubator. As we can see, it has got 6 chambers, and each chamber has got a capacity of 3. So here we place our embryos so that once we take up the embryos of the new patient, the air exchanges do not occur. Now that is a Hera cell. This we use to placing our media. It is at 37 degrees Celsius with a carbon dioxide of 6%. Now this is the ICSI apparatus, as you can see. And this is where the embryologist would sit down and inject the sperm in every single oocyte. Now, this is a laminar flow where he is working. As you can see, the digiblock is at 37, the laminar is at 37, well heated. He is scanning the follicular fluid. Just focus on this. Now, he is picking up each oocyte and placing them all together. So, he seems to have a good yield. Probably, sir, if you can focus, we can see it on the screen. This is how our oocytes look like with the cumulus all around. After this, he would be denuding the oocytes, and after some time, he would be proceeding with the ICSI. Meanwhile, the embryologist has taken the semen sample. It has been left in the incubator for liquefaction, and subsequently, it will be prepared for the ICSI. So, after the patient comes out of the anesthesia, we monitor the patient for a certain amount of time. We can focus on the screen. We can see the saturation is 94%, the pulse rate is 81, patient is stable, comfortable, and a short while we'll be shifting the patient outside. Thank you.